thank you for the invitation to record this author interview. My name is Bibi Mason-Slingerland. I'm a medical microbiologist working at the Erasmus University Medical Center, Rotterdam, the Netherlands. And in my work, I mainly focus on infection prevention, but also in research, I focus on this subject. And currently, I am supervising Koen in his PhD trajectory.
Well, my name is Koen van de Ploeg. I'm a medical doctor and a researcher, also at the Erasmus Medical Center. And my focus is on endoscope contamination and endoscopy-associated infections.
And in this video, we would like to provide you some background on our study that was published in Gastrointestinal Endoscopy. And the name of our study was called Contaminated Duodenoscope in Endoscopic Retrograde Cholangio Pancreatography, Sensitivity of Detection and Risk of Underdetection. So, Koen, why did we feel the need to do this study?
Well, in Erasmus MC, we maintain quite a large database of duodenoscope culture results, and that is because we have a microbiological surveillance of once a month. So each duodenoscope is cultured once a month, and if a duodenoscope is contaminated with what we call MTO, microorganisms of gut or oral origin, then the duodenoscope is contaminated and is only again cleared for clinical use if the subsequent culture is negative. Well, while I was studying the database, I noticed some kind of pattern. So a duodenoscope was contaminated, then the next culture where the duodenoscope was placed in quarantine was negative, and thus it could be cleared for clinical use, but the subsequent culture was positive again with a bacteria that in species name matched the original MGO. So that led me to thinking that we currently do not really have insight in the sensitivity of our current duodenoscope culturing detection methods, and if we are falsely clearing duodenoscope for clinical use, that means that we are exposing patients to contaminated duodenoscopes.
So why is that an issue?
Well, the issue with using contaminated duodenoscopes is that you have a risk of transmission from patient to patient. So bacteria can be transmitted from one patient to another and can cause infections. Also related to that is the reports that we have had of transmission of multi-drug resistant organisms.
So what does our study add to the existing knowledge?
Well, our main focus of our study was, of course, to get a range of the sensitivity of our current duodenoscope culturing methods, and also make an estimation of how many patients are currently exposed to contaminated equipment. So what our study adds is that, we established a range, and we saw that the sensitivity of our current methods might be as low as 82.2%, which shows that quite a significant proportion of patients might still be exposed to contaminated equipment. And this really highlights a crucial flaw in our current surveillance practices, and thus we think that we might have to revise guidelines.
So I hear you talking about guidelines. What should come next?
So based on our findings, we recommend a revision of the guidelines and to think about maybe we need more duodenoscope cultures in order to clean contaminated duodenoscope for clinical use. Also, we truly need more research to focus on enhancing the sensitivity of our contamination detection methods. And finally, we might want to think about enhancing our microbiological duodenoscope surveillance in order to prevent that patients are exposed to contaminated duodenoscopes.
Okay, thanks for the clear answers. Thank you for your attention.